Dr. Kurt Konkel. I practice in Milwaukee, Wisconsin, and Menominee Falls with Aurora Advanced Healthcare Orthopedics. I thought I'd talk with you today about some of the things, the exciting things that we're doing in the forefoot that have made life a little bit easier for patients and allowing them to be more active. One of the things that is a major problem in the foot is Hallux Rigidus, or a stiff great toe, typically from repeated trauma to the toe. This results in the painful stiffness and difficulty walking, stooping, and if it gets bad enough, markedly limits people's activities. The traditional way of treating this has been either by fusing the joint so it can't move and therefore it doesn't hurt, or removing the joint and leaving the patient with a floppy toe that moves but doesn't have any strength. Because of the limitations of these procedures, when an implant became available some years ago, I selected patients who wanted flexibility yet pain relief, or needed it because of their activities or avocations or job requirements, to have a hemi-toe implant put in their toe. And this is one of the hemi-toe made called a Futura implant, that we can remove part of the arthritis, put the implant into the base of the proximal phalanx, and you no longer have raw bone rubbing against raw bone, and allowing flexibility of the toe and pain relief. And I've done some studies that have shown that this will last for years and allows people to be more active if they're properly selected. Another common problem I'd like to talk about is bunions. It's important to listen to the patients and listen to their problems. One of the things that I noted early in my practice, that when you just took the bump off, there were many patients that would have recurring bunions. And I would see patients from other offices that would have recurring bunions. And gradually we recognized that there was an underlying problem, which was an increased spread between the first and second metatarsal bones. So we developed techniques to cut the bone and shift it over to correct the underlying problem. When we were doing those procedures, we needed to have the correction held until the bone had properly healed, and we'd use metal pins or screws. And patients were better and the recurring problems went away, but people didn't like the metal pins and the screws that were put into the toe because they'd have to be removed and were a source of pain. So some years ago, realizing that patients had problems with that, when absorbable screws came along, I started using absorbable screws that we could put in where the bunion procedure is done in the bone cutting, and these screws would not have to be removed, were not a source of pain or problems, and required no secondary procedures, so people were again much more satisfied with the procedure. So again, it's important to listen to the patients, to follow up with what you're doing, and recognize the limitations of what we're doing, so that when new materials and procedures come along that solve some of these limitations from previous procedures, we're quick to jump to those procedures so that we can have even greater satisfaction and faster recovery of our patients. Another common problem I'd like to talk about is hammertoes. Years ago, the treatment that was done for hammertoes when they bothered was to cut a part of the joint out of the toe, leaving the toe floppy, and very commonly causing pressure on the bottom of the knuckle, where nature wasn't intended to have all the pressure, and away from the tip of the toe. Because of this, we went away from resection arthroplasties, which left a floppy toe, and we started to do arthrodecies using metal pins. The problem with metal pins is it results in the toe having to be perfectly straight, and typically the metal pin has to be removed somewhere between 4 and 6 weeks, a lot of times before it's completely healed, leading to a scar union, but also a perfectly straight toe. In addition, if the patient stubs or has a problem with the toe, it could get in with the toe surgery. The pin could end up getting infected, the pin get bent or broken, creating other complications and problems for the patients and requiring a secondary procedure to get the metal out. A few years ago, a company came out with a absorbable plastic that can be put into the toe, and much like the metal pin, but the plastic can then be cut off so that it's totally embedded in the bone and not exposed to the skin, so there's no tendency to get an infection. Plus, the advantage of the plastic is after you get done with the surgery and putting it in, you can bend it so that when the toe heals, it heals with a more natural bend to it, and the weight on the toe is at the tip of the toe, which is where it belongs, instead of at the base of the toe. So patients have again been much more satisfied with this. The absorbable pin absorbs over a period of a few years and has not been the source of any problems in studies that I've done looking at it. So in general, it's important to realize the limitations of the procedures that we've done and some of the sources of problems for the patients, and when new materials become available, adopt them as you're able to lead to better results and much better patient satisfaction. Thank you.